Hi, I'm Mark Newman, the founder of Precision Analytical, and I want to answer a few commonly asked questions that we get about hormone testing and specifically the Dutch testing model. When you're looking at salivary testing or our Dutch model of testing, you're getting a pattern of the free cortisol as it changes throughout the day, typically highest in the early morning and then drops throughout the day. When you look at our test, you're also getting a diurnal pattern of cortisone. Why do we measure cortisone? That's a really good question, and it's even more complex than it really seems on the surface. When cortisol is made, that's the active form. The adrenal gland makes it, and that's cortisol ready for action. It's going to be highest in the morning and then drop off throughout the day. However, as it goes throughout the body in different compartments of the body, especially the colon, the saliva gland, and the kidney, it's going to get readily deactivated to cortisone, the inactive form, and now it can circulate as cortisone as well. So since a large fraction of it is circulating as cortisone, as well as cortisol, what the cortisone does, that daily pattern of cortisone, just simply helps to confirm that up and down pattern throughout the day. That's the simplest use of it. However, it gets more complex than that and nuanced in terms of the science, because the place you get your sample from, whether it's saliva or urine, there's a lot of that conversion going on, meaning the kidney, which is where your urine comes from, or the saliva gland, which is of course where your saliva comes from, in that local tissue, the cortisol, a lot of it is deactivated to cortisone. It doesn't go back, not in that tissue. It circulates as cortisone, and then it gets flipped back to cortisol, mainly in the liver, fat cells, and elsewhere in the periphery. So because of that uniqueness, the cortisone, as you see it in the urine, really presents sort of a shadow of that cortisol up and down. And so it becomes a good secondary marker for the diurnal pattern, but it also tells us a little bit about how heavily that deactivation is going on in that local tissue. Why does that happen? Because if all your cortisol came into your kidney and it was active, it's going to hit the aldosterone receptor, which plays into blood pressure and salt uptake. So because it does and cortisone doesn't, the body readily deactivates it to keep from that effect being excessive, and then it goes throughout the rest of the body and it has to get flipped back to cortisol to be in its active form. So if a particular patient has overactive deactivation, meaning the cortisol is really heavily getting shunted towards cortisone, in those cases, what you see in the urine, what you see in the saliva, may in some cases be a slight underestimation of what's really going on with the free hormone, but we can see it there in the cortisone. So it gets a little complex, but it gives you more information to really have a better handle on what's going on overall with the cortisol and the cortisone. Now, you may think, and it would be intuitive to say the relationship between the free cortisol and the free cortisone as we're measuring those tells us systemically and throughout the whole body which one of those is being favored. But as it turns out, the better marker for that is not to look at the cortisol in its free form and the cortisone in its free form. Look further down on our report. So if you're working off of page 5, as you look at the bottom of the report, you can see a better marker for this. This is the total of the cortisol metabolites relative to the total of the cortisone metabolites. Because that represents such a larger fraction of the entirety of cortisol and cortisone, that actually presents a better marker for which one is predominating, either the cortisol and the cortisone. What the scientific literature tells us is the relationship between the free hormones of cortisol and cortisone is not as reliable as a marker as the metabolites are. We look at which one predominates, cortisol metabolites or cortisone metabolites, and that tells us systemically which one is really predominating. Now, it may be that these two agree with one another. If the free cortisone is higher and the cortisone metabolites are predominating, then there's a very clear picture. But when they disagree a little bit, then we want to defer to the metabolites to tell us which one overall, because again, they represent so much larger of a fraction of the whole, is really predominating. So the balance between cortisol and cortisone is an important addition to all of this information that we're getting about cortisol, but we want to separate out the diurnal pattern and assessing whether that up and down pattern is happening appropriately from the question of which one's really predominating systemically, either the active cortisol or the inactive cortisone. And with all of the data that we have, we can properly ask all of those questions of a particular set of results and make more sense of it because we simply have more comprehensive information. So in that, the cortisone information really helps give a fuller picture to what's going on in a particular patient with respect to cortisol.